An 8-year-old child presents with high fever, new onset heart murmur, and painful swollen joints that literally jump from one knee to the other. If you see this diagnostic puzzle on your pediatric rotation or your exams, think of acute rheumatic fever right away. What is acute rheumatic fever? Acute rheumatic fever is an immune-mediated inflammatory disease that occurs as a complication of untreated group A beta hemolytic streptococcal pharyngitis. So, why does an immune-mediated disease affect the heart and joints so aggressively? To understand that, we need to dive into the pathophysiology. It always starts with a simple, untreated sore throat caused by group A beta hemolytic streptococcal infection. You get over the sore throat, but 2 to 6 weeks later, your immune system initiates a massive mistake, a type 2 hypersensitivity reaction. Here's how to understand it. Think of it as a case of biological identity theft called molecular mimicry. The streptococcal bacteria has an M protein on its cell wall. Our immune system creates antibodies that are like over-enthusiastic bouncers trying to kick out this M protein. But here's a catch. The M protein looks like structural twins with proteins in our own body. The bouncers get confused, can't differentiate friend from foe. For example, they start attacking myosin in our heart and keratin and collagen in our skin and joints. To make the diagnosis, we use the modified Jones criteria, but here is the golden rule. Before you look at anything else, you must have proof of preceding streptococcal infection. No proof, no rheumatic fever. The examiners love to test this. Look for ASO titer greater than 200. Once streptococcal infection is proven, you need 2 major or 1 major with 2 minor criteria. To memorize the 5 major criteria, just remember Jones. Joints, migrating polyarthritis. It's asymmetric, warm, and red. It's like a bad traveler. It stays in the knee for a day, packs its bags, and moves to the ankle the next day. Carditis. Carditis affects all layers. It loves to attack the mitral valve, causing mitral regurgitation. When you put your stethoscope on, you'll hear a loud pansystolic murmur at the apex. Nodules. Subcutaneous nodules. Painless, firm, little bumps that sit right over bony spots, for example like elbows. Erythema marginatum. A rare pink snake-like rash with a pale center. It looks like red marker rings on the skin. Sydenham chorea. It is an autoimmune damage to the brain's basal ganglia, causing rapid, jerky movements. Now, here is the ultimate exam shortcut. If a child presents with Sydenham chorea alone or late-onset indolent carditis, you can skip the Jones criteria entirely. You diagnose them with acute rheumatic fever on the spot. Now, what about the minor criteria? To remember this, think of the acronym FEAR. Fever, a high temperature. ESR and CRP elevated. These are inflammatory markers. Arthralgia, joint pain without active swelling or redness. Prolonged PR interval on an ECG, a sign of first-degree heart block. What are the other diagnostic methods? First, a full blood count to check for leukocytosis. Second, an ECG. You are looking for a first-degree heart block. A prolonged PR interval. If you see a rare third-degree heart block, that means severe carditis is actively taking out the conduction system. You may also see sinus tachycardia. Third, a chest X-ray. This helps you visually check for cardiomegaly. Fourth, an echocardiogram. This lets you visualize the exact valvular damage and look for Ascough bodies. Ascough bodies are classic sterile inflammatory lesions on the heart muscle. How do we treat this? It's a simple 3-step game plan. First, we need to kill the infection. Even if the patient is feeling better, we have to clear the remaining bacteria. We do this with intramuscular benzidine penicillin G. Remember, if the child has penicillin allergy, we can substitute it with erythromycin or azithromycin. Second, fight the inflammation. For joint pain, we give high-dose aspirin. But remember, if your chest X-ray or ECG shows severe carditis or heart failure signs, do not give aspirin. Aspirin can fluid overload them and worsen heart failure. In severe carditis, you substitute aspirin with prednisolone. Third, how long should we continue penicillin prophylaxis? Just remember the 5, 10 and the 40 rule. If there is no carditis, 5 years or until age 21, whichever is longer. If they have carditis but no permanent valvular damage, 10 years or until age 21, whichever is longer. If they have permanent valvular damage, 10 years or until age 40, whichever is longer. And that is pediatric rheumatic fever, completely simplified. If this helped make your studying easier, smash the subscribe button. Let me know what clinical topic we should conquer next, and I'll see you in the next video.